Hello, good day everyone. This is Dr. Mary Rose Birendon, and for today we will be discussing about the treatment of drug-resistant tuberculosis. So we are now on the case holding 2. Okay, so in the previous discussion, the treatment success rate of DSTB is at 90%. However, for the DRTB or the drug-resistant TB, our objective or the program objective is to achieve a treatment success rate of 85%. So we will I hope that I discuss along the way, we will be able to cover this all these 10 learning outcomes. So I will start with the NTP policies on the DRTB treatment. So first, treatment shall be started within 7 days from diagnosis. So as compared to DSTB, wherein our turnaround time from the collection of specimen to the initiation of treatment is 5 days. For DRTB, the treatment must be started within 7 days from diagnosis. Standard treatment regimens shall be based on patient eligibility and exclusion criteria. And we will also give individualized treatment to patients who will not be eligible for any of the standard regimens. The third is first and second line LPA. LPA is a line probe assay. It is a diagnostic test that shall be done prior to the treatment. So it ideally result should be within 2 weeks, or if you check with our MOP manual, it says there 10 days from submission of the specimen. And immediately, prompt adaptation of treatment shall be done if there is a seen resistance to fluoroquinolones or both high-dose isoniazid and prothionamide. So when we say prompt adaptation of treatment, it means that we will immediately adjust or we will immediately shift to a different treatment if we see additional resistance from the LPA test. Number 4, regular adherence counseling. And regular counseling must be done before treatment, 2 weeks after the treatment, and monthly throughout treatment. Although TB facilities with TB services shall establish a responsive treatment adherence mechanism that allows for the prompt follow-up of patients who interrupt treatment. So since DRTB treatment is more complicated, regular counseling is really important to ensure that our patients will really adhere to the treatment regimen. As compared kasi sa DSTB, we have 6 months treatment regimen and it's all oral, and you only adjust it or extend it if there are missed doses. However, in the DRTB treatment, the shortest regimen we have is 9 months already. Although we have, due to research, we have already come up with an all-oral regimen for DRTB, which is more responsive to our patients' need. However, there will be a set of criteria, eligibility and exclusion criteria for a patient to be given the all-oral treatment. So we will also be providing support to enhance treatment adherence. So as you all know, there is really a big budget or a chunk of budget the national, even from private agencies to support DRTB treatment, as this is still increasing in our country. So in the same way, we really are asking from the LGUs to support DRTB um, DRTB support mechanisms, like if we can give transportation allowance or cash transfers, if that would be applicable. Six, each patient shall be assigned a treatment supporter. So whether it's DSTB or DRTB, both will be needing treatment supporters. It can be a health worker, a trained lay volunteer. A family member is already considered a treatment supporter. That's one improvement or update in our sixth edition of MOP. And the drugs can be taken at home, in a designated community area, a workplace, or even in health facilities. Okay, so we can also use digital adherence technologies like we have those devices, no? So that is acceptable. And treatment monitoring. It shall be undertaken by using clinical microbiological, meaning we do smear microscopy or DSSM, and culture testing. And we also do laboratory investigation. 8, prompt management of adverse events. So the same with DSTB, DRTB has a lot more adverse events. And we really should be able to manage this to ensure compliance of our patients. So in case of adverse events, modification of treatment shall be done if there are cases of drug intolerance, and patients shall be promptly referred to hospital care for severe adverse events or for other comorbidities. 9, all serious SAEs or severe adverse events and adverse event of special interest. Later we will discuss what are these adverse events of special interest. This should be thoroughly recorded and reported through two mechanisms. We have the PBIMS, or the Pharmacovigilance Monitoring System. This is an online system wherein you can report the SAEs and the AESI. However, if this is not yet accessible to facilities, we can do the paper-based FDA suspected as adverse reaction forms and submit it accordingly. 10, treatment education. So there is a need to, even in DSTB, there is really a need to educate the patients and the family members for infection prevention control prior to the treatment and during the treatment. And we have this in DRTB, we have this TB MAC, no, wherein all difficult cases or whenever a patient need individual treatment regimen, it shall be discussed in the TB MAC, and um, the, the TB MAC comprises of doctors who are managing DRTB cases and who have been trained by the program on how to manage SAEs and how to do or how to make an individualized treatment regimen. This also includes different specialists in the country. So this will be our guide for the discussion. So now we start with education, counseling, and support to patients and family members prior to treatment. So it is very important to first, we inform the patient when they are seen to have the MDR or the RRTB disease. So it always starts with informing them of their condition, and the next step is really to educate what is TB and how RR or MDR-TB differ from the usual drug susceptible TB. And we also include here the nature of treatment, and really motivate them to undergo the treatment. One roadblock to starting a TB treatment is really the length of our regimen and the different drugs or adverse events that may happen during treatment. So for patients less than 18 years old, we can talk to the parent or guardians as well regarding the need for treatment. And if you can, and based of your on your assessment, if the child is able to understand, then I think it would also be good to include the child in the discussion, kahit yung mga simple terms lang. And we can provide the same with DSTB. We can provide necessary key messages for TB patients and their families. So we have to take note that health education is not a one-time, big-time activity. So hindi yan natin, like all of these key messages, no, ang dami, from basic information about TB down to the contact investigation, tracing mechanism. So it would be too heavy to discuss all of this to our patients prior pa lang to the start of the treatment. Baka that will be one of the reasons why patients will not go for treatment kasi natakot na sila. So what we do, as mentioned kanina sa isang policy natin, di ba, that counseling should be done prior, during 2 weeks after the initiation of treatment, and monthly thereafter. So dahan-dahan tayong mag-i-inject ng mga key messages in all of those timelines. Okay. So next, now after discussing the treatment, how important it is to start the treatment, we also discuss with patients their social and financial needs. Because nga DRTB treatment needs constant follow-up. Diba? Later on, you will see kung how frequent does DRTB patient needs to be follow-up. Unlike kasi sa DS, you just have like sputum follow-up 2 months after the intensive phase, and then on the 5th month and on the 6th month. But for DR, it will be there will be more rigorous monitoring. So so with patients, we have to offer possible sources of support, no, like if private paying or if employed, pwedeng sa SSS, GSIS. We also have the Employees Compensation Commission, DSWD, and yung sa ating mga LGUs, yung ating mga MSWD. And also, the program is, especially our partner PBSP, is also giving support to an extent possible. So now that you were able to discuss with the patient na the need for treatment, so what we are going to do before we actually do start the treatment is to do pre-treatment evaluation. So we determine other comorbidities and other health issues of the patients and manage them accordingly if not controlled. So we can refer them to specialists if needed. So the same with the STB, we do HIV co-infection, HIV DM co-infection, but now on a broader investigation, we also do need to check renal disease, history of cardiac disease, liver problems, history of cigarette smoking, alcoholism, drug use, and abuse, because this will all affect our treatment later on. We also do pre-treatment evaluation. So all DRTB patients are examined prior to the actual treatment. So our nurses or our physicians in the PMDT sites and the STCs would do clinical examination, including body weight and height. They still do smear microscopy. They do TB culture and drug susceptibility testing, first and second line probe assay testing, chest x-ray, and ECG. So baseline po talaga ito that needs to be done. Moreover, visual acuity and color vision test is done, serum potassium, BUN. So itong mga renal and liver panel test, no, including FBS, CBC, HIV, antibody test, Of course, this should have a written consent from the patient, and then pregnancy test is also done, TSH, mental health screening. So later on, you will know why mental health screening is mandatory prior to treatment. We also do brief peripheral neuropathy screening and baseline tests required for specific regimens. So later on, makikita natin if, for example, ito example na lang, no, isa sa mga regimen is our SLOR, um, fluoroquinolone resistant or for individualized treatment. So any regimen that contains delamanid, the drug delamanid, albumin must be taken as at baseline. And then if our regimen contains amikacin or streptomycin, these are aminoglycosides, injectables, no? So audiometry must be done. So yun yung mga specific pre-treatment evaluation. Now, we have discussed about line probe assay. So as I told you, this is a diagnostic test. This will detect resistance to various drugs. So for first line LPA, this determines resistance to rifampicin, high dose isoniazid, and low dose isoniazid. Why do we determine low dose isoniazid? Because this will also confer resistance to another drug which is proteonamide. For second line LPA, this will now detect resistance to fluoroquinolones and second line injectables. So yung mga amikacin natin. Okay. So line probe assay can be used as an initial test for patients with confirmed RR or MDR-TB, can be used for both pulmonary and extrapulmonary TB, and can also be used for diagnosis of XDR. Kasi nga, ang dami niyang drugs na na-detect for resistance, unlike ang ating expert, which only detects rifampicin resistance, no? So, kaya mas broader ang spectrum of diagnosis ng ating LPA. Now, how do we assign an appropriate DRTB treatment regimen? So, again, no, earlier I have mentioned that we have standardized treatment and we have individualized treatment regimen. So, for the standardized treatment, meaning standard siya, so it is defined ang group. So, all patients in a defined group or category will receive the same regimen. And however, for the individualized treatment regimen, this composed ito ng individuals or patients who are whose parang history has a previous TB treatment history, and may mga individual DST results that confers na hindi sila eligible for the standard treatment, and if they already have a history of contact with a DRTB patient. So, pag sinabi nating standard, defined na yung drugs, may exclusion and inclusion criteria, while for individualized treatment, wala po siyang defined drugs. It will be us who will determine kung ano yung magiging regimen ng patient base sa kanyang history, DST result, and history of contact. So, ayan. So, last week, we just na-introduce lang tayo sa 4 na drugs, which is yung HRZE. So, kung maatatandaan nyo, H is for isoniazid, R is for rifampicin, Z is for pyrazinamide, and E is for ethambutol. So for DRTB, we have to familiarize with all of these drugs and their abbreviation. So later on, if you, pwede nyo naman tong i-print and you put it in your desk so you won't forget. But this will be easy to memorize in the long run. Okay. And so LFX for levofloxacin, MFX for moxifloxacin, BDQ for bedaquiline, LZD for linezolid, clofazimine, CFZ, CS cycloserine, E ethambutol, DLM for delamanid, Z for pyrazinamide, IMP-CLN for imipenem, cilastatin, MPM for meropenem, AM for amikacin, S for streptomycin, PTO for proteonamide, PAS or PASER is for p-aminosalicylic acid, and HHD, ano nga yung meaning, yung H? H is isoniazid, diba? So, dagdagan mo lang na HD, that will be isoniazid high dose. Okay. So, later on, we will be using more of this abbreviation para mas madali for you to familiarize. Okay. So, now, I will introduce to you the different MDR or RRTB regimens for adults. Okay, so as mentioned earlier, we have the standardized treatment. So these are the standardized treatment. So yung regimen 1 and regimen 2 natin is yung for DSTB. So regimen 3 is 3 to 6 is for the DRTB. So we'll start with the standard short all oral regimen or SSOR. Yun yung ginagamit namin na gagamitin nating terminology. So, SSOR. So, for the SSOR, it can either be 9 months. Ito po yung pinaka-short. So, 4 months, 4 months plus 5 months, or it can be as long as 11 months. So, ang SSOR natin can be 9 to 11 months. Okay? So, later on, you will know kailan ba siya pwedeng 9 months lang or kailan siyang mag-extend up to 11 months. So, for the first 4 to 6 months of the regimen, you give, again, levofloxacin, BDQ, bedaquiline, meaning, bakit siya may 6 dito, open and close parenthesis 6? It's because BDQ shall always be given for a period of 6 months. Okay? So, and then CFC for clofazimine, PTO for proteonamide, pyrazinamide, ethambutol, and isoniazid high dose. And then, once the patient finishes this regimen, at this phase, you will enter the continuation phase kung sa DSTB pa for 5 months containing only these 4 drugs. Okay. Ang regimen 4 natin now is the standard long all-oral regimen for FQ means fluoroquinolones. So, ano yung mga drugs under fluoroquinolones? These are levofloxacin, moxifloxacin. Okay, so this is for fluoroquinolone susceptible, meaning susceptible pa, pwede pa siyang gamitin for the patient. So, pwede nating abbreviation dyan is SLOR FQS. So, pwedeng as long as 18 months to 20 months naman siya. So, for the first 6 months, you give levofloxacin, bedaquiline, linezolid, and clofazimine, and continue dropping the BDQ, kasi 6 months lang siya, diba? So, you only now give for the continuation phase, levofloxacin, linezolid, and clofazimine. Okay. And our regimen 5, kung yung kanina, fluoroquinolone susceptible, ang ating regimen 5 is SLOR fluoroquinolone resistant. So, meaning, either nakita sa ating line probe assay that the patient is already resistant to a fluoroquinolone. So, meaning, you cannot anymore give levofloxacin or moxifloxacin in this case. So, abbreviation natin siya, SLOR fluoroquinolone resistant or SLOR FQR. So, pareho lang, pwede siyang 18 to 20 months, but the difference is you do not give or you drop the levofloxacin or the moxifloxacin. Instead, you give BDQ, linezolid, clofazimine, cycloserine, and delamanid. And then, after this 6 months initial treatment, you drop BDQ and delamanid because you only give BDQ and delamanid for as long as 6 months. Hindi po siya natin, any use of 2 of these drugs more than 6 months is already off-label use. So, kailangan na ng approval ng TB MAC. So, matitira na lang is linezolid, clofazimine, and cycloserine. Okay. And ang last regimen natin is the individualized treatment regimen. So here, di ba sabi ko sa inyo, hindi na defined yung drug. It is the doctor, the physician, the STC physician, or the TB MAC who will now have to construct at least 4 to 5 likely effective drugs. So we will discuss more of that later. Okay. So, ayan. So, how do we now determine what is the appropriate DRTB regimen for our patients? So, first, if yung child, no, the same manner, we evaluate children with RR or MDR-TB for eligibility for the SSOR or the standard all-oral regimen recommendations for children. And then, we offer standard treatment if all the drugs in the regimen are available and accessible. So definitely, when we decide kung ano yung treatment for the patient, we have to ensure that all of the drugs are available naman. Kasi, like for example, pareho lang yan dun sa DSTB natin na when we give treatment or when we give the kit, no, or we assign a kit to a patient, we ensure na yung drugs niya kumpleto na for the full 6 months, hindi yung tingi-tingi. To ensure na hindi mapuputol yung treatment adherence ng ating patients. So for patients who are pregnant, contacts of patients who failed on an MDR-TB treatment shall be referred now to the TB MAC to design the individualized treatment regimen. Okay. So, prior to starting, we first really check exclusion criteria for the SSOR, especially for patients who are adults, not pregnant, and not a contact of patient who failed MDR-TB treatment. So, if, sa madaling salita, no, if patients are adults, pag sinabi natin adults, 15 years old po ang cutoff natin sa NTP program. So, if adults, 15 years old or above, not pregnant, and hindi po contact of a DRTB patient who already failed a DR treatment, are eligible to receive the SSOR if they do not have any of the exclusion criteria. So, una muna nating tingnan yung age, yung pregnancy status, and yung history of contact niya. Now, sabihin natin, adult patient, hindi siya pregnant, pasok siya, pwede siya for SSOR. We will now check yung exclusion criteria na naman sa SSOR. Because if meron po siya, kahit isa dito sa nakalista, then magiging hindi pa rin eligible si patient. So, first is severe intractable EPTB. So, this will already include yung mga TB meningitis, bone TB, even miliary TB. Kasi miliary TB is considered disseminated TB. And second, if based sa kanyang line probe assay test, nag-confirm siya ng resistance to fluoroquinolones, to moxifloxacin or levofloxacin. And then, if may exposure to fluoroquinolones, BDQ, clofazimine, and prothionamide for more than 1 month. Okay, ha? So, it is important to check yung time. Kung for example, na-expose lang siya to these agents less than 1 month, so pasok pa rin siya. Kasi ang exclusion criteria naman natin is really more than 1 month. Okay. For risk of toxicity or intolerance to any drugs in SSOR, so if any of our patients will exhibit any of the 4, so if my history of heart disease, the patient has heart failure, myocardial infarction, may mga ECG changes or may arrhythmia, if my QT prolongation or prolonged ang QT interval more than 500 milliseconds, there is a history of chronic active hepatitis wherein yung AST and ALT is more than 5 times elevated, no, from the normal, and there is history of chronic renal insufficiency or creatinine clearance with na less than 20 ml per minute, then definitely we cannot give the patient, or the patient is not eligible for SSOR. Okay, so aside from we start with the age, we start with the pregnancy status and the history of contact, we also look into this. So kapag may any check siya dito, then we do not give SSOR. Okay. So if wala naman exclusion, hindi part sa exclusion criteria ang patient, then we immediately start SSOR. And kung hindi naman po siya eligible, then now, pasok tayo doon sa next regimen, which is yung SLOR, yung longer oral regimen natin. But we start with the fluoroquinolone susceptible. Okay. So what are the exclusion criteria for SLOR fluoroquinolone susceptible? So, ayan. So, confirmed resistance to fluoroquinolone. So, definitely, hindi mo na, ito pa lang, no, number 1 pa lang, kung may fluoroquinolone resistance na siya, then definitely you cannot give this SLOR FQS. Kasi nga, ang sinabi natin, di ba, you only give fluoroquinolone S or SLOR FQS if susceptible pa siya doon sa fluoroquinolone drug. Again, the same kanina, no, exposure with these 4 drugs for more than a month, and a history of same pa rin, heart disease, QT interval of more than 500 milliseconds, chronic hepatitis, and renal insufficiency. What is notable din dito is we also check now for severe anemia. Severe anemia means hemoglobin of less than 8 grams per deciliter. So, ayan. Because isa sa mga drug, later on we will discuss, isa sa mga drug o na part ng regimen 4 for SLOR FQS may cause severe anemia or may cause has effects sa ating bone marrow or nagkakakos siya ng bone marrow suppression. Okay. So, check eligibility. If may isang check dito, then hindi na natin pwedeng ibigay si SLOR FQS. But if not, then we can start the treatment for SLOR FQS. Now, if hindi pa rin eligible si patient, for example, meron siyang anemia, hindi pa rin talaga siya eligible for SLOR FQS, then we proceed to the eligibility or the exclusion criteria for SLOR FQR naman, for regimen 6. Okay. So, again, FQR means fluoroquinolone resistant. So, the same pa din, same drug, include natin dito BDQ, linezolid, cycloserine, clofazimine, or delamanid, again, exposure more than 1 month. Risk of toxicity, the same lang po with SLOR FQS. Okay. So, definitely, ang makikita natin, which is really common to all, is itong history of cardiac disease, chronic hepatitis, renal insufficiency. So, pag nakita nyo pa lang from the onset na may ganito na si patient, mukhang hindi na siya kaagad eligible for all of the standard regimen. Then, papasok na yung individualized treatment regimen. So, if wala siyang na-check dito, then we can proceed with a SLOR FQR regimen or regimen 6. If hindi pa rin siya pasok, then we now refer the case to TB MAC for the individualized treatment. Okay, so okay. So For patients wherein sa pag-design sa effective treatment regimen nila, um, based sa existing recommendations, no, later you will know ano ba yung recommendations for designing an individualized treatment. If talagang hindi na possible yung recommendations for the ITR, then itong bedaquiline, pretomanid, and linezolid or the BPAL regimen will be considered now as the last resort of treatment. However, when we do this, kailangan may strict implementation of um, drug surveillance, yung ADSM natin, drug surveillance monitoring, and really this has to be consulted with the TB map. Okay. So now I will just show you yung summary nung exclusion criteria natin for the three regimens I mentioned earlier. So we have SSOR, we have the slower fluoroquinolone susceptible and the slower fluoroquinolone resistant. Okay, no? And then ito yung mga exclusion criteria as mentioned earlier. Okay. So, ano yun? Pag sinabi nating may yes to any of these exclusion criteria, definitely hindi mo na pwedeng ibigay yung regimen. But if no, so ibig sabihin, you can still proceed with the regimen. So, pwede nyo tong balik-balikan as you go along para mas clear sa inyo and mas madali nyo siyang maalala. Okay. Okay, now. So, now we proceed with the individualized treatment regimen. Don't be intimidated with the individualized treatment regimen because, again, diba, as I always mentioned earlier, once the patient is not anymore hindi siya pasok for the standardized treatment regimen, then ano yung unang-unang gawin is to refer the patient or the case to the TB MAC. So we have a regional TB MAC composed of our PMDT and STC physicians and specialists. And kung hindi naman kayang ma-resolve ng regional TB MAC yung case because it's too complicated, we also have guidance from the National TB MAC, doctors from the Lung Center of the Philippines, and specialists of DRTB who will help us design the drug. So, kumbaga, hindi na sa atin yung burden. But it's good to know how they do it, no? How the TB MAC does parang paano nila ginagawa yung treatment per patient. Okay? So, may principles. They are guided on various principles. So, eto no. So, makikita nyo, we have groupings of the drug, Group A, Group B, and Group C. And then we have kung ano yung drugs under them and the abbreviation. So, familiarize nyo muna kung ano yung mga drugs under each grouping because this will easily help you out later on in deciding for the individualized treatment regimen. Okay, so bakit siya naka-group? Ano yung basis ng grouping? The basis of the grouping is based po siya sa efficacy and the safety of the individual drug. So, pag nandoon po siya sa group A, meaning ito mas maganda ang kanyang bacterial activity for the Mycobacterium tuberculosis and less din yung expected na kumbaga yung safety profile niya ay less than the rest of the drugs. And then as you go higher doon sa grouping, medyo bumababa din yung efficacy and mas yung adverse events mas likely or mas marami siyang adverse events. Okay? Sige. So, ang principle lang naman dito is yung ITR, yung individualized treatment regimen, should include, anong sabi kanina, 4 to 5, at least 4 to 5, or the least siguro 4, pinaka-minimum, likely effective drugs. So, ang idea dyan is we use or we exhaust medicines under Group A muna, and then we only proceed with Group B and Group C if may drug dito sa groupings na Group A na hindi pwede sa patient. Like for example, meron siyang resistance to fluoroquinolone, so definitely tanggal na kaagad ang ating levofloxacin and moxifloxacin. So meron na lang tayong dalawa. We have bedaquiline and linezolid. So now, kailangan pa natin ng dalawa because sabi nga, di ba, 4 likely effective drugs. So now we choose ko sa group B and then sa group C if needed. Basta makompleto natin yung 4 to 5 likely drugs. Okay. So, yung ating pyrazinamide dito sa group C, counted lang po siya as an effective agent only if yung drug susceptibility testing result ng patient will show evidence na susceptible pa siya for pyrazinamide. So we do not give pyrazinamide immediately or we do not consider pyrazinamide immediately in the regimen if wala tayong DST result. So as much as possible, we have to wait for the DST result. And for our bedaquiline, yung sabi nga natin, no, ang safety and effectiveness of bedaquiline, since this is a new drug, a novel drug, ay hindi po determined beyond 6 months and for children below 6 years old. So sufficient yung studies and yung review of bedaquiline in this scenario. So use of bedaquiline, na-mention ko na to kanina, beyond 6 months and for children below 6 years old is off-label na. Pag sinabi nating off-label, meaning beyond na siya doon sa recommendations given. So what should be done is this has to be referred to TB-MAC. Dapat na-approve ng TB-MAC and dapat you get the patient's consent or the parents' consent na naintindihan nila the risk of using bedaquiline for off-label use. Okay. So same din sa delamanid. So these are novel drugs. Okay. So however, for delamanid, kung ang bedaquiline natin is less than 6 years old, for delamanid is below 3 years old naman yung cutoff for the age para mag-off-label use. Okay. So imipenem, cilastatin, or meropenem. So if we consider this treatment regimen for our patients, every dose of these 2 drugs mentioned is administered with amoxicillin with clavulanic acid, However, yung available formulation lang kasi dito sa Philippines of the clavulanic acid is combined with amoxicillin, which is yung ating co-amoxiclav. So kaya what we do is, kasi for every dose of imipenem or cilastatin or meropenem, we administer co-amoxiclav, and kasi parang kuanto sila synergistic yung kanilang effect. So pero sa counting mo ng 4 effective drugs, hindi nyo po ika-count si amoxiclav as an additional effective TB agent. Yung imipenem or meropenem lang. For amikacin naman, amikacin or streptomycin. So these are our injectables. Iko-consider lang natin siya only again if the DST, drug susceptibility result, will confirm susceptibility doon sa drugs na to. And again, during testing for audiometry, maganda pa yung quality of audiometry monitoring. So wala tayong nakikitang hearing loss sa patient. So saka lang natin siya i-consider. Kasi medyo may effect talaga siya sa hearing capacity of the patient. So we don't want na nabigyan nga natin ng drugs si patient, pero naging bingi naman siya after ng treatment niya. So we don't want that to happen. So yun yung mga tinitingnan natin. Okay. And detectable ang ating susceptibility when we do yung ating sinasabi nating line probe assay. So it is very important na talagang makomply yung mga different laboratory tests. Yung kanamycin and capreomycin, it is no longer recommended for use in the MDR-TB regimen. Kasi mas malakas yung kanilang side effect towards hearing loss. Sige. Okay. So, ito na yung sinasabi ko. Ano yung basis ng ating pag-craft ng individual treatment regimen? Ano yung basis bakit we have groupings of the drugs? So, meron kasi tayong tinatawag na core drugs, no? Core drugs are drugs in a regimen that contributes most to relapse-free cure. So, meaning, less likely na magre-relapse si patient after ng treatment niya. Kasi yun naman yung gusto natin, di ba? Na we give the most important drugs first para the patient will adhere to the treatment regimen kasi mahaba siya. And then, we also give it because it does not provide, or it does provide relapse-free cure. So, the core drug has both moderate to high bacterial and sterilizing activity. So, ayan. So, we have here bacterial activity column, sterilizing activity column, and resistance prevention column. So, this core drug is given throughout the treatment, and based on studies, it is well tolerated and confers no cross-resistance with other drugs in the regimen. So, ayan. So, samples dito yung ating mga 4th generation fluoroquinolones. Ito no, moxifloxacin, meron pa nga tayong gatifloxacin, and dabedaquilin. So, mataas ang bacterial activity, mataas ang sterilizing activity, and least likely na mag-resistant siya. Kumbaga, yung cross-resistance with the other core drugs. Yan. Kaya kung pansin nyo, ito yung mga nasa group A drugs natin for the ITR. Okay, next. We also have companion drug. Companion drug. So yung companion drug, we give it to avert treatment failure due to acquired drug resistance against the core drug. So like for example, kasi common dito is yung fluoroquinolones because nga it's widely used na, no. So again, ito yung siguro magandang i-discuss natin with all our patients, hindi lang sa TB patients but in other cases, no, na talagang hindi maganda yung self-administration of antibiotics because mas nagke-create ito ng drug resistance to different diseases. So, mas mahirap nang mag-treat ng disease kasi wala na tayong gamot that will be effective against the agent. Okay? So, meron tayong companion drug. So, yung companion drug is parang a drug used kasi mataas yung bactericidal effect niya. Although, may mga companion drug na low yung sterilizing activity. So, in general, our regimen must always include a core drug plus at least one companion drug with high bacterial activity and or 2 sterilizing companion drugs. But as mentioned earlier, if okay po si patient sa all group A drugs, then unahin po muna natin siya. And then before lang po natin siya i-add ng mga drugs under group B and group C. So yeah. Okay. So kailan ba natin masasabi, no, that the drug is considered a likely effective drug for MDR-TB? So first is the drug has not been used in a regimen that failed to cure the individual patient. So, nagamit na siya before, pero nag-fail din to treat the patient. So, wag na natin siya uling gamitin ngayon. Kasi nag-fail na nga siya. And baka it will just create more resistance. Next is the DST or the drug susceptibility testing performed on the patient's strain indicates that it is susceptible to the drug. Okay. So, susceptible pa siya doon sa drug na ibibigay natin. So, walang resistance. No known resistance to drugs known to have high cross-resistance. So, ito, fluoroquinolones, yung ating second-line injectables, isoniazid, and prothionamide. No known close contacts with resistance to the drug. For example, in the family, yung isang member of the family was diagnosed with RRTB, and then nakita na resistant siya. Yung the father, for example, it's the father is on ITR, individualized treatment regimen, kasi nga marami siyang resistance pattern. So, you do contact tracing sa family, di ba? So, you also screen the family baka kasi meron na rin silang TB. So, if the child is, yung child is seen to have manifestations of TB and yung only contact niya is ang father niya, who is may known resistance to the drug, and then siya yung close contact, then definitely, baka i-consider natin, mag-IITR din siya if diagnosed siya to have MDR-TB. But syempre, kailangan pa rin ito with the drug susceptibility test results. So, ayun ang ano. In the absence of DST or unreliable DST, the results of drug resistance survey, we do the national program together with private partners conducts drug resistance surveys, no? I think yung pinaka-latest nila is 2018. So, kung unreliable yung DST or yung wala tayong DST result, then pwede natin gamitin yung survey, yung results ng survey, if yung patient natin ay may similar grouping doon sa mga patients na included sa survey. So, if the drug is pasok po siya dito, no, hindi ginamit sa regimen in the past, walang susceptibility, may susceptible pa, so pwede pa siyang ma-include natin as likely effective drug. Ano pa yung mga principles when we design the individualized treatment regimen? So, di ba, ang sabi natin kanina, bedaquiline is only used for 6 months. So, dapat, after mo ni-stop si bedaquiline for 6 months of the regimen, meron ka pang may iwan na 3 likely effective drugs for the rest of the treatment duration. So, kung ma-observe nyo kanina doon sa SSOR, di ba? After nung intensive phase, 4 to 6 months, natatanggal si bedaquiline, naiiwan si linezolid, clofazimine, and cycloserine. So, mayroon pang 3 effective drugs that will be used for the duration of the treatment. Okay. So, now, we go doon sa steps to consider in designing an individualized treatment regimen. Basta yung main aim natin is to design a regimen that will contain at least 4 likely effective drugs. Pwedeng more than 4 if kailangan, and may doubt tayo sa effectiveness of any of the first 4 drugs. Lalo na if may mga patient tayong nakita na ang dami-daming resistance patterns. So, step 1, again, use all group A drugs first if possible. So, we use higher generation fluoroquinolones, either levofloxacin or moxifloxacin. So, hindi natin pwedeng gamitin si moxifloxacin or we avoid using moxifloxacin if based on ECG findings, our patient has multiple QT, um, is already using multiple prolonging drugs, or makita din natin sa kanyang ECG na meron na siyang prolonged QT interval. And then, if um, if naman may na-detect na low fluoroquinolone resistance, pwede tayong gumamit ng moxifloxacin dose at a higher dose ng moxifloxacin. Pero hindi lang natin siya i-count as one likely effective drug. So, bedaquiline, yung use of bedaquiline natin may be considered only for 6 months. Pero use of bedaquiline more than 6 months is already under off-label use. And when we do this, TB-MAC, it has to be approved by TB-MAC and it has to have proper ADSM to ensure that the benefit always outweigh the risk. Okay. So for linezolid naman, yan, linezolid, it may be used for the whole course of the treatment if tolerable. So again, diba, monthly po tayong mag-check ng mga adverse events of our patients and we properly record it. If hindi naman tolerable, we can decrease the dose to 300 milligrams per day or 600 milligrams per day, full dose, pero gawin nating alternate. Kumbaga, MWF, ganon siya. Kasi isa sa mga adverse events that may happen in long-term use of linezolid if myelosuppression, peripheral neuropathy, and optic neuritis. So if late po natin na-stop si linezolid and hindi po natin na-monitor ng maayos itong mga parameters na to, then pwedeng maging irreversible na yung mga adverse events, which we don't want to happen to our patients. Okay. Step 2, if DST, urine drug susceptibility testing, is not available, cycloserine or clofazimine, hindi po natin siya pwedeng ma-count as one of likely effective drugs. So, very important that we have the DST result. So, clofazimine, hindi rin natin siya pwedeng gamitin if, I'm sorry, okay, back tayo doon. If DST is not available, si cycloserine and si clofazimine ay hindi natin makakount as a likely effective drug if both has been used more than 1 month in the previous treatment. Okay? Okay, no? So, kung walang DST result, hindi natin lang i-count yung dalawang drug if nagamit na more than 1 month in the previous treatment. And if contact siya ng MDR patient na nag-fail on the regimen containing these drugs. So again, I would like to clarify that we can still give clofazimine and cycloserine if DST result is not available, but it will not be counted as a likely effective drug if both have been used more than 1 month in previous regimen and if your patient is a contact of an MDR-TB na nag-fail on the regimen that contains these two. Okay, so I hope that is clarified. Okay, for step 3, add group C drugs. So marami-rami na yung group C drugs, diba? If the 4 likely effective drugs cannot be made from groups A and B. So, ito, sa group A, you have 1, 2, 3. You have 3 drugs. So, if pwede si patient dito sa drugs na to, mag-add ka na lang ng isa, pili ka dito sa dalawa to complete the 4. However, for example, hindi siya pwede sa levofloxacin, BDQ and linezolid lang. So, you add the clofazimine and cycloserine para maging 4. However, sabihin natin, hindi siya pwede sa fluoroquinolone, hindi rin siya pwede sa bedaquiline kasi sabihin natin, less than 6 years old siya. And ayaw mong gamitin mo na siya for off-label use. So, you have linezolid, clofazimine, and cycloserine. So, tatlo na lang. So, that's the time na pipili ka ng isa dito sa group C. Okay. So, assignment of the regimens. Okay. So, ito yung parang algorithm that you can use to make it easy. So, first, you have to diagnose the patient as RR or MDR-TB using expert testing. So, if mataas ang suspicion nyo that this patient is possible RR or MDR-TB, like for example, ilang beses nang nag-failed for a DSTB, naka-twice na siyang mag-DSTB, tapos talagang nagpa-positive pa rin for talaga for MTB. So baka RR. So pwede na kayong mag-collect ng 3 sputum specimen for LPA, line probe assay, sputum microscopy, TB culture, and DST test. So ayan. So now, you will treat na the patient. The patient agreed to be treated as our MDR-TB patient. So first, di ba ang sabi ko, i-determine nyo muna kung adult na ba siya, meaning 15 years old and above, tapos hindi pregnant, and yung history of contact niya. So, pwede siya sa SSOR, i-check nyo na ngayon kung may exclusion criteria ba siya doon sa SSOR. So, if no, you can start SSOR and you wait for the results of the first line and second line LPA and phenotypic DST. So, kasi ang sabi natin, di ba, paminsan kasi yung results ng LPA and DST will take about 2 weeks before bumalik sa inyo. And ano nga yung isa sa mga principles natin, isa sa principles natin of DRTB treatment is to start the treatment 7 days from diagnosis. So whether or not the LPA or DST results is already available, then we can start the TB treatment already. So, ayan. Tapos, i-adjust nyo na lang siya once the LPA and DST result comes in. Okay. So, for example, meron siyang exclusion criteria for SSOR. Kahit isa lang, di ba? So, hindi na siya pwede kaagad for SSOR. So, now, proceed na kayo to check the exclusion criteria for SLOR FQS. If wala siyang exclusion criteria, then start SLOR FQS and then check results for LPA and DST. If meron po, then hindi siya pwede sa SLOR FQS, then proceed to check exclusion criteria to SLOR FQR. Ito yung resistant na sa fluoroquinolones. If wala pong if no doon sa exclusion criteria, then start SLOR FQR and then wait for LPA and DST. If meron naman to any, then it's now time to consult the regional TB MAC to present the case para makadesign tayo ng individualized treatment regimen. So again, huwag kayong matakot because it's really the regional TB MAC who will decide for the ITR. Okay. So we follow the recommended regimen for TB MAC, from TB MAC, no, if it's an ITR. And then, if gagamitin naman natin some of the drugs for off-label use, like yun nga, sabi natin, no, we have to ensure na it is properly documented, yung mga properly documented sa TB MAC, and then the monitoring for the ADSM, yung mga adverse events, ay in place din po. So, ano ba yung mga situation that requires off-label use of anti-TB drug to TB MAC? So, kailan ba natin na sinasabi na, ay, ginagamit ko na itong drug na to for off-label use? Meaning, out na doon sa initially recommendations based on research. So, first is use of bedaquiline and delamanid in combination. So, once we use these two novel drugs in combination, off-label use na po yun kaagad. Yung ito, kanina ko pa mini-mention, extended use of BDQ and or delamanid for more than 6 months. So initially, dapat 6 months lang talaga siya maximum and you have to stop both drugs. But if there is a need, kung baga wala ka na talagang options doon sa mga drugs from group A, B, and C that can be a likely effective drug and ito na lang talaga yung bala mo. So you can extend for more than 6 months as off-label use. And then use of bedaquiline and delamanid in extrapulmonary TB. Sa age group naman, yung bedaquiline, if ginamit siya for less than 6 years old and pregnant patients, and for delamanid for children less than 3 years old and pregnant patients. Okay. So, in general, informed consent is really required for patients who will be enrolled under Regimen 5. Bakit kaya? Ano kaya yung nasa Regimen 5? The Regimen 5 is the SLOR FQR. So kung babalikan nyo po sa Regimen 5 ay nagamit po kasi in combination si BDQ and si delamanid. So off-label use na po siya. And patients who need extension of BDQ and delamanid. Okay, so once the patient agrees to use anti-TB drugs under off-label, so ask the patient to sign the informed consent. And para naman sa patients who cannot be fully informed, like if less than 18 years old or younger pa, if mentally incapacitated, then we seek consent from the patients or the guardian. Okay, so this is a sample patient information sheet and consent form for off-label use of bedaquiline. So guided naman kayo kung paano nyo i-explain sa patient and sa caregiver or sa family. So ano nga yun ulit? Review lang. Use, kailan siya? Off-label use if more than 24 weeks or 6 months. If used in combination. If used in pregnancy. Children less than 6 years old for BDQ. Less than 3 years old for delamanid. And if gagamitin siya for EPTB. Okay. So, yan, yung discussion will, bakit importante, ano yung important information you should know about these two novel drugs, and then, ilahad talaga natin sa patient na ano yung hindi known regarding sa safety profile of the two drugs. Yan. Okay. So, after determining now the treatment regimen, we follow the recommended dosing for adults and children. So, guided naman po tayo, in the dosing of the medicines. Hindi na tayo kailangan mag-compute, no? Meron na po ito kaagad. Meron din po ito doon sa MOP manual that we will be giving you. Siguro for now, kuan muna soft copy. But, next year, hopefully, magawa natin ng paraan to have the hard copy with us. Okay, so, ayan. So, naka-grouping na rin yung drugs, A, B, C, and yung others. Okay. So, ito siya ay ang dosing of medicine na gagamitin natin for children 15 years old and above. So, ito meaning for adults to siya. So, ito makikita natin, dito nakalist yung type of medicine for ito yung weight-based daily dose. So, ito yung basis sa pag-compute netong mga frequency of drug administration. And ito yung mga available formulation of our drugs. And ito naman yung weight band. No? So, check nyo lang dyan kung saan nagbilong ang patients nyo. Yeah. Then, a few special remarks regarding the drugs. So, sample lang, no? For fluoroquinolones, like for example, for levofloxacin, we have two formulations, the 250 milligrams and the 500 milligrams. So, if your patient is 34 kilograms, so papasok siya dito sa weight band na to. So, you give it, ayan, give 3 tablets if you use 250 milligrams and you give 1.5 if you use the 500 milligrams tablet. So, ayan siya. Okay. So, ano lang siguro yung mga special concerns natin dito. For imipenem, ayan. Ito na yung ano, imipenem na wherein ano nga yung dapat na ibinibigay always as a companion to imipenem or as a synergistic drug together with imipenem yung ating clavulanic acid. But since we don't have the preparation na clavulanic acid lang, so we give coamoxiclav. Okay. So, imipenem is administered twice a day, every 12 hours. So, every 12 hours siya. So, it is in IV po, IV form. So, we incorporated it to a 100 ml solution before being infused for 40 to 60 minutes. Okay. So, there is always a risk of phlebitis, obstruction, or inflammation on the site of insertion. So, we just advise the patient na i-properly care dun sa site of administration. Okay. So, kailan ba natin binibigay yung coamox? So, before the infusion, binibigay na natin yung amoxiclav in 875 milligram per 125 milligram tablet preparation given 30 minutes before the procedure. And then, sa second infusion, kasi di ba nga, binibigay natin siya every 12 hours, no? So, sa second infusion, you can instruct the patient to take 1 tab of amoxiclav 30 minutes prior na naman. Okay. So, ito naman yung dosing of medicine for less than 15 years old. So, meaning, ito naman yung pedia dosage. So, ayan. We have the groups A, B, and C, and the drug, and the subsequent dosages. So, you can just refer to this, no? Ayan. So, for SSOR and our ITR, Individualized Treatment Regimen, containing prothionamide, we can start prothionamide in 2 divided dosage. So, pwedeng morning and evening muna siya for the first 2 weeks of treatment. If total daily dose is more than 250 milligrams. Kasi may mga patients na hindi nila ma-tolerate yung prothionamide kasi isa sa mga side effects of prothionamide is vomiting, nausea and vomiting. So may mga patients na hindi kaagad nila ma-tolerate, lalo na if more than 250 milligrams, mataas ang dose. So what you can do is pwedeng start mo na siya in divided dosage, morning and evening for the first 2 weeks. And then after that, you can, if ma-tolerate niya na, pwede na siyang yung hindi na kailangan i-divide yung dose. And para talagang to counter the side effects, you can advise the patient to take prothionamide after a light meal lang. So, ayun na, yung sinabi ko kanina. Once tolerance has improved, you can change the prothionamide dosing to once daily after 2 weeks. So, ayan. So, you have started the regimen na, and then now, after 2 weeks, you have received the first and second line drug susceptibility results of your line probe assay and phenotypic DST. So, once dumating na yun, we now revise the regimen accordingly, depending kung saan yung susceptible and saan yung may mga resistance patterns. So, again, no, yung LPA, ating line probe assay, will check for the presence of fluoroquinolone resistance, high-dose isoniazid resistance, and PTO resistance. So, yan. So, may guide na rin when to shift and when to continue. So, for example, your patient is on SSOR. You started the patient on SSOR. Dumating ang baseline LPA and showed, sabihin natin, ito, wala siyang resistance sa fluoroquinolone with resistance to high-dose isoniazid detected but no resistance to PTO or low-dose isoniazid. So what you do is you just continue SSOR. Pag naman PTO siya may resistance or sa low-dose isoniazid, you still continue SSOR. But if there is no resistance detected for fluoroquinolones but has resistance to both high-dose and low-dose isoniazid, kasi again, sabi ko, ang low-dose resistance to low-dose isoniazid confers also resistance to PTO. So pag meron siyang ganito, what you do is you shift now the patient to another regimen which is the slower FQS or fluoroquinolone susceptible. Pwede mo pang ibigay si fluoroquinolone dahil wala naman siyang resistance pattern, di ba? And continue dose count if shifting happened within 1 month from treatment initiation. Okay, you have to be careful with that. No? Like for example, naka-SSOR pa siya. Nasa 3rd week pa lang siya ng SSOR niya. And then nakita niyo tong pattern na to. So what you do, shift niyo yung regimen niya to slower FQS and then i-continue niyo lang yung counting. So meaning nasa 4th week na siya ng kanyang treatment. If less than 1 month. Sabi nga natin, 3 months pa lang siya. Okay. Ito naman. For fluoroquinolone resistance, nakita natin yun, meron siyang resistance pattern. So whether or not positive or negative siya for high dose or low dose isoniazid, you now shift sa slower FQR. Meaning, hindi na tayong pwedeng magbigay ng fluoroquinolone. And then, for this, since isang very likely effective drug, group A drug po, ang fluoroquinolone, then we really have to restart the dose count. So meaning, like, for example, nasa 3rd week na siya on SSOR, pag shift nyo siya sa slower, hindi nyo po i-count yung 3 weeks treatment niya sa SSOR. Magsa-start po siya 1st day talaga to a slower FQR treatment. Okay. So the same goes dito po sa ibang regimen. Okay. So ayan. So if LPA result is MTB detected, no? Other LPA results po tayo, is MTB detected, invalid for MTB detection or indeterminate resistance for any drug, and yung result is received before treatment, before treatment or within 2 weeks from start of treatment, you can recollect sputum specimen para i-repeat yung LPA testing and you just continue the regimen. Just continue the initial regimen. So for example, nasa SSOR na yung patient nyo and then ito yung results and then hindi nyo pa siya nabibigyan ng treatment or within 2 weeks pa lang from treatment initiation. Kolektahan nyo na po siya mag-recollect po kayo ng sputum and then you continue the initial regimen and you wait for the result of the repeat LPA. But if the LPA result, whether initial na ito or repeat, ay na-receive na within 2 months of treatment, then you have to adjust the regimen accordingly. Yeah. So if LPA result, for example, nagkaroon ng problem with our LPA testing, nagkaroon ng delays, and more than 2 months po, or may mga pagkakataon na hindi available yung LPA testing, then we correlate with the patient's clinical condition, sputum smear, and culture results. So, pag nakitaan natin, my sputum culture conversion, or my clinical improvement, and so we continue the initial regimen. Pero if there is no culture conversion at month 4 of treatment and wala din pong clinical improvement, and nagkaroon pa ng recurrence ng TB signs and symptoms with culture reversion, meaning no, nag-negative na siya before tapos biglang nag-positive ulit, then we repeat our drug susceptibility testing, DST, both LPA and phenotypic DST, and consult the case with TB-MAC. So TB-MAC will help you decide if you continue initial regimen or you wait na lang sa result ng repeat DST. So follow the same procedures upon receipt of the phenotypic DST result. So in case of discordant result between LPA and phenotypic DST, ipa-follow natin yung worst result. Meaning, pag sinabi nating worst result, it is the result with more drug resistance. And consult the case with TB-MAC for regimen revision, if needed, if kailangan i-revise. Moreover, if the phenotypic DST or other molecular DST from a quality assured reference laboratory ay nagpapakita ng resistance to paracetamide and or ethambutol, then the case has to be discussed also with TB-MAC for regimen revision if needed. Okay. So this we will skip muna because this will be discussed on a different na module. So now, pasok tayo sa initiation of treatment. Okay. So, in the initiation of treatment is important pa rin ang reporting and recording. So, I think you will have it next week, yung reporting and recording na. So, skip mo na lang muna natin to. And discuss and finalize the appropriate treatment adherence mechanism. For example, nakapili na, okay, SSOR talaga. So, i-determine na ng patient and the caregiver or treatment partner kung saan tayo mag-meet up for the treatment or for the drug intake, yung most suitable location for drug intake, and you also now determine sino yung magiging treatment supporter based on the patient's condition. So, pwedeng family member, health worker. And again, same with DSTB, if yung daily intake ay hindi po possible na sa health facility, then the health worker can provide initially a 1-week supply to the treatment supporter. So 1 week muna, test muna natin kung wala bang mga missed dosing. And then, if nakita natin that after, for example, 2 weeks, 3 weeks, that walang missed dosing and talagang na-adhere sila doon sa treatment regimen, then we can later on adjust to a maximum of monthly dispensing. So same with DSTP pa rin. Maximum natin of dispensing is 1 month. But this will still be depending on the situation. Like, for example, now, we are in a pandemic and it's lalo na yung may ECQ. So, we considered a maximum of 2 months naman. So, we ensure that the health workers or yung trained volunteer will regularly communicate with the patient every 2 weeks for psychosocial support. So, pasok pa rin dito yung other modes of supervision such as yung mga SMS, video call, if available. Okay. So, I think we will stop muna sa initiation of treatment. I will make another video discussing treatment monitoring until post-treatment follow-up. So, thank you very much for listening. I hope that you were able to get the information needed for starting or initiating the MDR treatment regimen. Thank you.